So we are on one more edition of Oncology Beyond the Obvious. And if you look at the two logos on the top side, on the one side is a magnifying glass close to the eye, which is commonly shown in detective movies. So we are taking a closer look as detectives for the benefit of our patients. And why this is necessary is shown on the left hand side, which represents iceberg. And as you all know, the majority of the iceberg is under the water. So there are so many hidden finer points which have to be, gone through before we decide whether the conclusion in the publication is right or wrong. So a landmark paper is called so, but whether it's really a landmark paper and whether the conclusion of the authors is similar to what will happen in real life or not is the big challenge. And that is the reason why we thought of doing this series on oncology beyond the obvious. With that introduction, it is my pleasure to introduce Dr. Amish Vora, my co-program director. He's senior medical oncologist in Delhi, and I think he runs the most successful daycare center in Delhi. I know of several daycare centers that started and then collapsed and closed in Delhi, but this guy is, providing a unique bouquet of services which are not available anywhere. So, with that brief introduction, Amish, can I hand over to you?
Thank you so much, sir. Today's paper which we have selected is CheckMate 577, that is adjuvant immunotherapy, nivolumab, in esophageal cancer. The idea of selecting this paper is that based on one large randomized trial, there is a category 1 recommendation in NCCN guidelines, and this has also been incorporated in many other guidelines. There is a full publication in New England Journal of Medicine in the month of April on the same. So we thought it is apt that we discuss CheckMate 577 today. Kashish, can I have my first slide, please? I'm just going to briefly outline what is CheckMate 577. Next slide, please. As I said, NEJM, April 1st, 2021, this year. Next slide, please. The trial design, it's a global phase 3 randomized double-blind placebo-controlled trial. Key eligibility criteria was stage 2 and 3, esophageal and gastroesophageal junction cancer. Both adeno and squamous cell carcinoma were included. Neoadjuvant chemo plus radiotherapy in concurrent fashion, followed by surgical resection. R0 resection had to be there, and randomization should be within 4 to 16 weeks prior the surgery should have been completed. Residual pathological disease was mandatory. Whether you have YPT1 or you have YPN1 or both, this had to be there with a good performance status patients, of course. There were 3 predetermined stratification factors, that is squamous versus adeno, lymph node positive versus lymph node negative, and tumor cell PD-L1 expression less than 1% or more than or equal to 1%. 794 patients were randomized in 2:1 fashion between nivolumab and placebo. For the maximum duration of 1 year, nivolumab was 240 milligram fixed dose every 2 weekly for 16 weeks, followed by 480 mg every 4 weekly. Primary endpoint is DFS, and I mentioned this is because there was some amendment which I'm sure we will discuss during panel. Secondary endpoint was overall survival, and there are many other exploratory endpoints. Next slide, please. As you can see, both the arms patient characteristics were well matched. What I would like to point out that tumor location, that is esophagus, was in 60%, while GE junction was 40%. Now, adenocarcinoma was 70% and squamous was 30%. Like you would expect squamous to be little more because there were more patients of esophagus. And there were 70% of the patients who had PD-L1 negative or less than 1%. There were 57 to 58% of patients where lymph node was positive in terms of residual disease. Next slide, please. Primary endpoint was met at the follow-up of 22.4 months. That is, the median disease-free survival in nivolumab arm was 22.4 months, while in placebo it was 11 months, with the hazard ratio of 0.69 and p-value of 0.001 and less. Next slide, please. If you categorize or differentiate between squamous and adenocarcinoma, squamous carcinoma did better. That is, the median DFS in squamous cell esophagus was 29.7 months compared to 11 months with hazard ratio of 0.61, while in adenocarcinoma, it was 19.4 months versus 11.1 month in placebo with hazard ratio of 0.75. Next slide, please. This is a forest plot chart. In the forest plot chart, almost all the subset benefited, except for a few which crossed the line of unity, and we will discuss that. I would let Senthil comment on that. Next slide, please. Safety-wise, grade 3 and 4 were exactly identical in the nivolumab arm and the placebo arm. There was no new safety concern. There was not a single death on nivolumab arm. Next slide, please. With this in the background, I invite today's interviewee, Dr. Senthil Rajappa. I don't think anybody in the audience would be so naive not to know Dr. Senthil Rajappa. Still, Dr. Senthil is a senior medical oncologist in Basavatarakam Indo-American Cancer Hospital, Hyderabad. Senthil did his DM from Kidwai Memorial Hospital, Bangalore in 2001. He was in Nizam's Institute, Hyderabad for many years. He has been awarded Best Teacher by Tamil Nadu State, and I'm sure everybody would agree to that award. He is instrumental in starting DNB in the current hospital and in the previous hospital where he has worked. Senthil is, excellent speaker, moderator, reviewer, whatever you call. And as Dr. Somashekhar and many others said, he is like, emeritus moderator. I think he is going to retire as that. But Senthil also is writing, he writes very well. I still remember one of his review article on bevacizumab, I think 10 years back, Senthil. And many of my doubts about bevacizumab got cleared reading that review article. And I'm really, really happy reading all his publications. But if you have to remember Senthil, or if you have to describe Senthil in just 1 or 2 lines, what would it be? I'm sure many of you would have seen the Hollywood movie called Troy, where Brad Pitt played the role of Achilles in the famous War of Troy. And one of the soldiers at that time told, I live in the times of Achilles. And I'm sure all of us would agree that we can say that we are living in the times of Dr. Senthil Rajappa. And with that, I welcome you, Senthil, on this platform.
Thank you. Thank you so much, Amish. Thank you for that very flattering but very humbling introduction. If I'm even a small percentage of what you have described so far, my day is done. We can close this interview and you can ask Dr. Somashekhar all the questions. Thanks so much, Amish. Thanks so much, Amish.
Thank you, Senthil. And please trust me, we are going to trouble you again and again on this platform. With that, let's start today's discussion, Senthil. Before we embark on our discussion on CheckMate 577, some rapid fire questions to you, Senthil, with expected rapid answers.
All right.
Okay. Stage 2 and 3 CA esophagus in your practice. If nodes are positive, are you satisfied labeling them on CT scan alone, that is more than 1 centimeter, or would you like to do an FNAC?
Ideally FNA, but if you can't, we get on with it.
Okay, ideally FNA, but otherwise CT scan. Squamous cell CA esophagus, all patients on neoadjuvant chemo plus radiotherapy in your practice?
Almost all except the upper 1/3. When I say upper 1/3, I'm talking about definitive chemo RT in that population, but the middle and lower 1/3 would go for surgery after chemo RT.
Correct. All same for adenocarcinoma esophagus also?
Not adenocarcinoma. So in our hospital, the type 1, type 2 G junction, they go in for chemo radiotherapy followed by surgery. The type 3 is treated like stomach. Sometimes we have a difference of opinion about how type 2 should be managed, but then that's on a case-by-case basis.
Okay, so that means perioperative chemotherapy in those type 3.
In some patients.
In some patients, okay. Your choice of chemotherapy during radiotherapy, paclicarbo, 5-FU cisplatin or capecitabine plus oxaliplatin?
Paclicarbo.
Paclicarbo, okay. Post-surgery, if there is an R0 resection, before CheckMate 577, was surveillance the key?
Yes.
And those who achieve R1 resection?
Pray.
Okay. In your clinical practice, relapse rate post R0 resection?
So that depends upon whether somebody's got a pathological complete response or not. If you got a pathological complete response, you still have a 20-30% chance of getting the disease back. If you've got residual disease, then that percentage can go up to 70-80%. Higher the relapse rate if the nodes are continuing to be pathologically positive. So it's a wide spectrum in terms of the relapse rate itself.
Right. So non-pathological complete CR, YPT1N0 versus YPN1 versus N0. What would be the relapse rate?
So YPT1N0 would be somewhere around 50%. N plus would be somewhere around 70-80%.
Okay, 70 to 80% when the nodes are positive in pathological.
Absolutely.
Once relapsed, how many of your patients reach second line Senthil?
Around half of them, 40-50% would get to another line of therapy.
And 50% will not.
50% will not. For various reasons, starting from they don't think it's worth it, to they're not fit enough to take any therapy, and so on and so forth.
Once relapsed distantly in the second line or in the third line, how many of your patients end up receiving immune checkpoint inhibitors?
Very few.
Very few. Okay, perfect. So I think with this, the standard of care, and I'm sure I think all of us follow the same. Once we have established this, Senthil, let's start discussion on CheckMate 577.
Absolutely, yes.
Do you think, was there an unmet need to carry out this trial, CheckMate 577?
Yes, there was certainly a need to carry this out. And the reason is, first, you didn't have any adjuvant therapy at all for patients with esophageal squamous cell carcinomas and GE junction carcinomas, assuming that we're talking about type 1 CWAT if it's an adenocarcinoma. Patients who did chemoradiotherapy and then had residual disease, as I said, we didn't have anything to offer. If they were pathological complete responses, still we didn't have anything to offer in spite of that relapse rate being somewhere around 20-30%. So I think this was an area where we certainly needed therapies. This is not like breast cancer where you already have 3 therapies and you're trying to build up on that. Here is a situation where you didn't have any therapy at all to improve outcomes for these patients. So I think this is an absolute need.
Okay, perfect, Senthil. I completely agree with you. Senthil, I have always seen in your moderation, you try to dissect out the study trial design. So let me ask you this question. Stage 2, 3, squamous and adeno both together, clubbed together in one group. Incomplete PAT-CR is the only one which was studied. Nivolumab versus placebo. 794 patients with a pre-specified p-value less than 0.036 and hazard ratio of 0.72. Are you okay with this trial design? Would you have made squamous or adeno separate, or would you have included PAT-CR R0 resection also?
So let me answer the last question first. I think whenever you're doing a trial of a drug in the adjuvant setting, you always want to look at patients who are likely to do poorly. And irrespective of the anatomical subsite, post-neoadjuvant chemotherapy or chemoradiotherapy, patients who have residual disease are likely to do poorly. And that's the group of patients that you would select to do a trial like this. So from that standpoint, I think it's fine. Should you have taken patients with pathological complete response also? I'm tempted to say that I would start from how much was the disease load to begin with, right? Because though we know PAT-CR is very good, where you started also matters. So let's not get into that discussion today. Probably it's for another day. But I think the inclusion criteria is perfectly all right. The second question in terms of whether you should have not included GE junction, I think the practice today, at least in most parts of the world, is that if it is esophageal squamous cell carcinoma or a type 1, type 2 GE junction carcinoma, even if you look at the NCCN guideline, the category 1 recommendation is for chemoradiotherapy. Yes. Right. So that's the starting point for this study. So anybody who is eligible for chemoradiotherapy and then ends up having residual disease went on to get the adjuvant therapy in terms of nivolumab versus placebo. So from that standpoint, I think in terms of inclusion, both patients who don't achieve a pathological complete response and patients who have GE junction adenocarcinomas who are eligible for chemoradiotherapy, and squamous cell carcinomas middle and low 1/3 who are eligible for chemoradiotherapy followed by surgery, obviously get into the study. So from that standpoint, I think it's absolutely fine, the inclusion-exclusion criteria.
Excellent. And your p-value and hazard ratio. So let me ask one more question when you answer that pre-specified p-value and hazard ratio. I nowadays keep hearing only hazard ratio in every talk. Senthil, do you think hazard ratio has become more important than p-value in today's oncology world?
So I think the way we should look at it is like this, Amish. The hazard ratio gives you the magnitude of benefit.
Right.
And what is good, what is not good, as I always say, is beauty lies in the eyes of the beholder. Whether 0.8 is good enough, 0.7 is good enough, or, Adura, 0.17 is still not good enough for some people. So I think beauty lies in the eyes of the beholder. So that gives you the magnitude of benefit. The p-value tells you how sure you are about that, right? So I think both are important. But if you ask me to choose between these two, the first thing I will choose is the hazard ratio, because that tells me the magnitude of benefit. And anything that's less than 0.05 in general, and from a statistical consideration, if one has to look at a lower p-value, that is still acceptable to me. But between the two, hazard ratio is more important.
So hazard ratio of 0.85 with a p-value of 0.00001, still not enough for you, Senthil?
No, I would not be happy, because that hazard ratio, I would say, is not clinically significant. It is statistically significant. So that's the difference.
That's the difference. Okay. Senthil, surgical details were not pre-specified in CheckMate 577. Were you worried with that? We will go into the details of results later, but in terms of the trial design or anything, they are not pre-specified surgical details.
Yes, Amish, I'm a little unhappy about the fact that the details of the surgery in terms of selection of centers and surgeons, what should be the quality of surgery, how do you define good quality esophageal and GE junction cancer surgery was not defined. I think that is certainly one of the negative parts of this study itself, because we need to understand that surgery is the most important part here. We are adding on to surgery. So I think if you don't define good quality surgery to begin with, then, the rest of it can always be questioned to whatever extent it can be.
Right. I think in the panel, Dr. Somashekhar would go into the details of the surgical aspects and advantages of it. The next question, Senthil, one of the big questions for today. As you said, we are living in the worlds of PFS or DFS, I think last 2 years. First, we had Adura in non-small cell lung cancer. Then we had Solo-1 in ovarian cancer. Then we had Olympia in breast cancer. Then we had adjuvant pembrolizumab in RCC. And now we have CheckMate 577. All these trials, the primary endpoint was DFS or PFS, whatever you want to call it. The first three, Adura, Solo, and Olympia, has already been incorporated in guidelines. So is CheckMate 577. You had attended the Olympia webinar as Dr. Sudeep Gupta had given his viewpoint. I would like to ask your viewpoint, Dr. Senthil Rajappa. Is PFS good enough, or are we jumping the guns without waiting for overall survival before changing our practice?
Okay, let me start by saying that overall survival is the best endpoint. It is the most robust endpoint, and that is what all of us want to see. And I think there is no doubt about it. Yeah, yes, Amish.
Sudeep, when you say overall survival, you are talking of adjuvant setting only, because there was some discussion in our WhatsApp group. There's a difference between metastatic setting and adjuvant setting.
I think in any setting, we want to make sure that patients live longer and patients live well. I think these are two very important issues that we always want to achieve. But I think we need to also look at what is achievable from a clinical trial standpoint, right? So in terms of the size of the trial, the kind of patients who have to go in, the longer duration that is necessary for getting an overall survival benefit. So that's the reason why we look at these surrogates. So when you look at DFS as a surrogate for overall survival, you need to interpret in that context. So why do I say context? Because let us say you have a super hazard ratio in terms of the DFS benefit with a significant p-value, right? Let us look at the example of CheckMate 577. Let's look at the overall results of the study, a DFS that is doubling from 11 to 22 months in a situation where you don't have any standard therapies at all. I think that is clinically very significant, not only statistically significant, and a hazard ratio of 0.69 is also clinically significant. Now, in certain subgroups of patients, it's not only a doubling of the DFS, it's actually a tripling of the DFS. Let's look at patients with esophageal cancer. 8 months, a paltry 8 months is the DFS that you get compared to 24 months that you get with nivolumab. Similarly, in patients with squamous cell carcinoma, 11 versus 29, that is nearly a tripling of DFS. So I think when you have a huge magnitude of benefit, tripling of DFS, doubling of DFS, then there's a high likelihood. I didn't say it will always. There's a high likelihood that this will translate into an overall survival benefit when you wait. Now, it is not only important to live, it's also equally important to live well. You don't want to live with disease, continue to go to the hospital all the time, taking immune checkpoint inhibitor or chemotherapy, see your doctor's face every 3 weeks for the rest of your life, especially in the era of the immune checkpoint inhibitors. Third important issue is, as we started discussing, what percentage of patients will really go ahead and take treatment when you tell them this is not curative, this is only likely to prolong your life, right? And when I said some patients don't take it because they don't want to take it since it's not curative, some patients, general conditions are not good, and so on and so forth. So remember that with every line of therapy, there is an attrition. So when you're given your best chance, you use that best chance. Now let's look at another situation where you're getting a PFS benefit, DFS benefit of some 3 months, right? That is statistically significant, but clinically not significant. Then in that kind of a situation, for me, DFS is not agreeable as a surrogate for overall endpoint. Now, in that situation. So I think this has to be interpreted in the clinical context, in the setting, what therapies are already available, and how is it that you are going to salvage your patients. I think all this needs to be taken into consideration when you decide, is this acceptable as an endpoint for me or not?
If it is acceptable by all these parameters, you would not hesitate changing your practice standards based on DFS as primary endpoint. Yes or no?
Absolutely. Absolutely. Yes.
Okay.
Yes.
Perfect. So, Senthil, you already mentioned about the PFS and adeno and squamous both. So I would not repeat that. There were, in the trial also, in addition to that, there were 396 events, which was more than 85% of 420 events which they had specified. There were 366 recurrences, 30 deaths. All were because of disease. There was no new safety signal as regards nivolumab. There was not a single death in that 1 year because of nivolumab. Okay. Were you expecting these results, or were these results of CheckMate 577 was unexpected according to you, Senthil?
A difficult question, Amish. So I didn't know about CheckMate 577 till I saw CheckMate 577. So I wouldn't know what I expected really. But I think I'm impressed.
Were you surprised?
I'm happy. I'm not surprised. I'm quite happy because this is a signal that you're getting in quite a few subsites now, as you rightly pointed out: kidney cancer, urothelial cancer. That's another area where immune checkpoint inhibitor seems to be doing well in the adjuvant setting. So I think I'm not very surprised. I'm quite happy. And also, if you look at the DFS curves, you like to go and dissect that a little bit. Though the separation happens a little late, around 6 months, it continues to remain really parallel, Amish. I think that's very important. It's not getting close to each other as you get to longer follow-up. That parallel DFS, not as separated as Adura, but it's really running parallel, and which means that that benefit is likely to remain for a longer period of time. And then you look at distant metastasis-free survival, which is again better for nivolumab. You look at the DFS2, which is now going to be a reasonably accepted surrogate for overall survival. That's also better with nivolumab. So I think there are so many things that are in favor of nivolumab here in this study, which are impressive and which is good enough for me to change practice based on 576.
Okay, I wanted to come to forest plot question, but before that, Senthil, we have 5 more minutes. I just wanted, there's something surprising in this NEJM publication. There was not a single Kaplan-Meier curve for overall survival. That was, even if it is not statistically significant, even if they are overlapping on each other, almost every author, every group publishes that. Why was it not there in this publication, Senthil?
I wish I knew it, Amish, but I'm not going to be able to give you an answer to that question. But I think we can be reasonably sure that the survival is not going in the opposite direction. The reason is because you're seeing such a benefit in terms of DFS, and at least as of the data that we have in the tables of follow-up, we're not seeing any signal of a detriment or increased deaths in the nivolumab arm. So I don't know why they didn't. It would have been great if they did, but I don't think one has, there is a detriment, and that's not something that we are seeing, at least based on the data that is available.
So you would not read too much into absence of OS Kaplan-Meier curve right now?
Okay, I would have been happy if they had shown it, but then yes, it's a sore point. I agree that.
It's a sore point. So coming on the sore point, the second last question for today, Senthil, what were the drawbacks of CheckMate 577?
I think one is that you didn't show the overall survival Kaplan-Meier. We would have liked to see that. The second important thing is, I think the standards in terms of surgery was not clearly defined. I think that's an important negative point as far as I'm concerned. The third important issue is, you could have pre-specified and done the analysis based on PD-L1 CPS, rather than TPS.
Tell me more about it, Senthil. IHC 28.8, something like that, which, I was initially embarrassed that I don't know about it. But so tell me more about PD-L1.
So I also didn't know about it, Amish, but then I've heard about it. Probably a little better there. So in this study, they looked at using the TPS rather than CPS. CPS being what we have used in most anatomical subsites other than lung cancer. And
Right.
they also used 28-8, the antibody on the DECO platform, rather than using the ones which are much more commonly used, to 22C3 or the SP263. So they had a pre-specified subset analysis based on TPS, right? And they did a post-hoc analysis on CPS. And the post-hoc analysis on CPS showed that there was greater magnitude of benefit for patients who had a CPS of more than 5. Will we be using this in clinical practice? I would say no, because this is not a pre-specified subset analysis. Though we know that a positive CPS predicts for activity of the immune checkpoint inhibitor, we can't rule out the benefit in negative. So you can go dissecting and say that I will choose patients only who have a CPS that is positive or more than 5. That's left to you. But the appropriate way of interpreting this data is that since it's not pre-specified, we will only know that it is predictive. It's not negative predictive.
Senthil, in fact, I'm surprised when you say this. In the forest plot chart, the CPS or the PD-L1 less than 1%, in fact, more than 1% is crossing the line of unity. And in fact, would you take that into consideration? And quickly about, should we pay too much attention to these forest plot line of unity crossing and not crossing?
So the TPS story, I would not take that into too much of consideration, because if you look at the confidence intervals that are really too wide, so I would not give too much credence to that TPS story, at least based on the forest plot. So when would you give consideration and take the forest plot story, for making some decisions in clinical practice? One, if it's a pre-specified analysis. Two, if it's not a pre-specified analysis, but you've still done the statistical correction necessary with an interaction key that is statistically significant, defined based on what your correction is. And three, if you have something that is not expected, but you have a biological hypothesis to really explain the phenomena that you're seeing on the forest plot. So these are the situations where I would really interpret the forest plot and take that into consideration to make clinical decisions. Otherwise, if you're not powered, if your interaction P is not significant, and if it's not pre-specified, I would not really give too much consideration to that forest plot. But then it's there. You have to see, all of us are human beings, so we interpret it to the way that we like it to be, and then take it into consideration depending on what merit we think it is for.
I think it has to correlate with her past experience and what already has been published when we look at the forest plot. That is something which I got from you and Sudeep and by reading about that. Senthil, congratulations to you about your commentary on CheckMate 577 being accepted in IJMPO. I read that. It was really good. But my last question for today, Dr. Senthil Rajappa, the Dr. Senthil Rajappa. Based on
I'm glad you didn't say it, Dr. Senthil.
Based on CheckMate 577 results, stage 2-3, CA esophagus, trimodality treatment, where surgery R0 resection is achieved, but pathological complete response has not been achieved. You would not hesitate to offer nivolumab, or in other words, this is a practice-changing paper according to you.
Yes.
That's great. That yes is very confident, and that gives a lot of confidence to us. Senthil, you have to stay back for panel, but I cannot thank you less. Thank you so much for giving your insights. It's really, really heartening to understand and get your viewpoints. With that, I hand over to Dr. Parikh, sir. Thank you, Senthil, again.
Thank you, Senthil, and thank you, so Amish. It is nice when we have a very clear-cut answer from our expert being interviewed. And I think the emphatic yes was really nice, as Amish pointed out. Okay. Now it is my great pleasure to introduce our moderator for today, Dr. Bharath Rangarajan, who is the Senior Medical Oncologist and Chief of Medical Oncology at Coimbatore. We have worked together at Tata Hospital, and then from far I have seen how he has, progressed, especially since he takes a very practical and a patient-oriented approach to his treatment of patients. And I can share with you that I am saying this from the patient's point of view as well. I am alive today because of how he managed my illness when I was in Coimbatore during one of the ICON conferences. So with that little introduction, I must hand over the mic to our moderator. But before that, can I ask the Kavina Creations team to introduce the esteemed panelists with whom Bharath will be interacting.
Thank you, sir. So the panelists for the panel discussion are Dr. Anant Ramaswamy, medical oncologist from Mumbai, Dr. Randeep Singh, medical oncologist from Gurugram, Dr. Hollis D'Souza, medical oncologist from Mumbai, Dr. Viraj Lavingya, medical oncologist from Ahmedabad, Dr. Nilesh Lokeshwar, medical oncologist from Mumbai, Dr. S.P. Somashekhar, surgical oncologist from Bangalore, Dr. Pooja Nandwani Patel, radiation oncologist from Ahmedabad, and of course our interviewee, Dr. Senthil Rajappa, medical oncologist from Hyderabad. Over to you, Bharath, sir.
Is my screen visible?
Yes, sir, your screen is visible.
Thank you for that wonderful introduction from Dr. Parikh. And I have really wonderful panelists today. Of course, the interviewee, Dr. Senthil Rajappa, has really left almost nothing uncovered. Everything has been covered because we are only covering aspects of the trial. We are only dissecting, or rather splitting hairs about this. But it's very important because, as both Dr. Parikh and Dr. Amish said, we are going to take extremely important decisions for our patients immediately, in the next few months, based on these trials. We call them landmark trials. We look for these category 1 recommendation. But I think it is not just about category 1 recommendation. It is about what Dr. Parikh wanted to make the difference is there is a difference between category 1 recommendation and a level 1 evidence. So the thing is, we are looking at whether this is level 1 and category 1 or just category 1 for now. Category 1 means, everybody in NCCN panel agreed that this is the best that we can do for our patients at this point of time, and it can change in 6 months or even lesser than that, or at next ASCO, when new data comes up. But level 1 is different. So let's have a sort of, recap of what Dr. Amish and Dr. Senthil have done. My slide is not moving for some reason.
So can you move your mouse or use the arrow keys? So can you use the mouse?
Yeah. So the panelists have been introduced by Kavina. I must apologize, Dr. Lavingi. I have written your name as Viraj in almost all slides. I apologize, it's Virat. So we have gone through this first slide. I have put on only very few slides of the actual trial. Reason being, we know that it's been presented. We know the data from this trial. So we're just discussing the how we are going to apply it in practice tomorrow. So it is stage 2, stage 3, esophageal cancers and gastroesophageal junction carcinomas, both adeno and squamous. 70% to 71% were adeno carcinomas of either the esophagus or gastroesophageal junction, and a small proportion, around 30%, of squamous cell carcinomas. Stratification factors pre-specified, very important. Histology squamous versus adeno. Pathologically, YPN1 versus YPN0. The YPT has not been stratified. And tumor PDL1, it was TPS, not CPS. We have gone through the rest of the trial. Now, NCCN specifically includes GE junction along with the esophageal carcinoma, and it has done for a few years now. But if you look at Asian studies, the studies that come out of China, Japan, Korea, usually the GE junction adenocarcinomas are grouped along with gastric adenocarcinomas and not along with esophagus. So whatever the NCCN says, but the Asian groups have actually gone their way and classified the GE junction along with gastric carcinomas. So we must remember that it's not always about NCCN alone. And the issue is, because of this classification by NCCN, we get a very confusing heterogeneous group of esophagus and GE junction, of adenocarcinoma and squamous. So two sites which may be slightly different biologically, and two histologies which are definitely different biologically. I don't think anybody has a difference. The only site where adenos and squamous are grouped together is carcinoma cervix, and there the argument is both are HPV related. But Dr. Nilesh, let me start with you. As of now, are you an American or are you Asian? By Asian, I mean Far East Asian. Do you put your GE junction adenocarcinomas and squamous cell differently? Has flot cross changed your practice? And CheckMate 577 is not just about adjuvant nivolumab. CheckMate 577 is about what you do as soon as you see your patient. So, it impacts your neoadjuvant chemotherapy as well. So what does it impact your planning for neoadjuvant?
Thanks, Bharath. Very much Indian and very much Asian in my outlook and in this subject also. I have felt right from the initial cross study to this present study that our distribution of GE junction, squamous and adenocarcinoma is quite different from what is represented in most of these clinical trials. And to answer your first one, correct, that the first question that you asked is GE junctions, adenocarcinomas. In my clinical practice, I prefer to treat the perioperative way, that is the flot 4 pre-surgery and then 4 more. Whereas squamous cell carcinomas, mid or lower esophagus, as much as possible, prefer to do it the way as described in the cross protocol. And as you also rightly mentioned, there is a very big difference at a molecular level between squamous cell carcinomas and adenocarcinomas. We know that squamous cell carcinomas are more representative, similar to head and neck, whereas in the adenos, we have 4 different subtypes of molecular signatures, including the EBV and others. And while they are clubbed often in most of these clinical trials, I think we see a different population at our centers.
So I think that's a very important point. The trial included everything and the trial gave approval for everything as category 1. But I think a lot of us are uncomfortable. I am uncomfortable. Nilesh is uncomfortable. I want, sort of very short answer from Dr. Anant, who sees a lot. It's a large volume center. TMH is a large volume center. And he sees esophagus and adenocarcinomas from 2 different units. From the thoracic, at least it was like that from my time. I know it's ancient time, 14 years back. but still from thoracic unit and from GI unit. So, Dr. Anant, I don't know what the practice in TMH is now, but could you, answer the same question, but in a brief manner?
I'll just add the few points I looked up before attending the panel. The 3 studies that we got to consider are the old cross, the modified flot by Albatran, and the neo-aegis. So I was just looking at the data, the 3-year survival endpoints, which is common for all 3 trials. They're actually the same. The cross overall 3-year survival is 57% when you give NACT-RT and surgery. The current data is also 57%, and the flot for adenocarcinomas is also 55%. So one of the points that Dr. Amish had asked, actually Dr. Senthil, is, are you happy with, OS not being presented? That I think is a major issue, before we take this as a category 1 recommendation, in my viewpoint.
We will sort of come to it.
So right now it's NACT-RT in squamous and flot in adeno-CA across the board.
Across the board. Dr. Senthil, are they same or are they different in your opinion?
You're talking about squamous and adeno?
Yes.
Bharath?
Yes.
Okay. Squamous. So what we do at our hospital is the squamous.
No, what we do. No, I really not about what we do. Do you think they are the same disease?
They're not
they should be treated similarly or not?
They should be treated differently.
They should be treated differently. So let's start with that. That many of us may not agree on this trial selection criteria, at least in our practice, day-to-day practice. But of course, we have to accept the trial as it is published. That's a different thing, but we may not accept this inclusion. Dr. Pooja, just going a bit forward, this trial had CVOT 1 and CVOT 2 and 3 also. And how would you, sort of think of radiation for CVOT 1 and CVOT 2, 3? Is it the same technically? Are you really expecting the same sort of results in terms of PCR when you're radiating a CVOT 1 versus a CVOT 2, 3?
So definitely we expect a difference in response, and that is why probably the CVOT 3 we would like to treat as probably a stomach and more as that sort of management. Whereas the CVOT 1 would be definitely treating as an esophageal one. 2 is a little bit dicey. It is always a controversial thing. We keep it in the tumor board and then decide what was the best way of managing it.
So now with CheckMate 577, would you feel comfortable? Okay, they have done chemoradiation for everybody, regardless of histology and regardless of CVOT. So, would you be comfortable doing cross sort of therapy for everybody?
Not really.
Would CheckMate 577 change your practice? Because unless it changes the practice at that point, you cannot discuss adjuvant.
So as of now, it would change the practice, but I think having said that, maybe more patients' experience would really help us to know that whether it can really change our clinical practice.
So
as of now,
so I would assume that CVOT 3 you will still not be comfortable taking up for chemoradiation upfront.
Yes.
Okay. With that, I'll just go to Dr. Anant. I think Dr. Anant has
interviewed Randeep.
Yes.
So there were 2 points what Anant was saying. I think when we see the MAGIC trial, we were very worried about the post-operative, whether how many patients will go for a post-operative ECF, and that fear got abolished when flot came. I mean, it was 50% post-operative chemotherapy in MAGIC, and that came down to 25 to 30% of loss. And the majority of the data, the MAGIC, the excitement of the cross trial was mainly in the squamous. If you see, there was a huge difference in squamous compared to adeno.
Yes. So point taken. Randeep, can we just move on and come to it a bit more detail later?
Okay.
Yeah. So Dr. Anant, the reason is Dr. Amish has told me that we must look at everything from the perspective of 577 and try to analyze it that way. That's the only reason, so that we dissect this trial. Basically, but I take your point that a perioperative chemotherapy for adeno is very much possible, and so that should not be the reason to drive patients to cross-based therapy. Am I right, Dr. Randeep?
Yes.
Yes. So a cross should not be driven by the fear that we will lose patients in the perioperative or post-operative setting. So very important point taken. So Dr. Anand, so yeah, actually I think we've covered this. Any point that you want to add, in the sense that does CheckMate 577 support neoadjuvant CCRT for everybody? Because you need a pathologic stratification, and that is provided. So does it provide that framework for treatment for everybody?
I would not. I would wait for the overall survival results, and specifically if you're talking of the adenocarcinoma, I would definitely wait for the overall survival before shifting to NACTRT in esophageal adeno CS. No.
Okay, so
squamous, yes, there is no doubt.
So the panel, by and large, seems to say that 71% of patients who received adeno and then nevo, they would not have given a chemoradiation upfront. So having understood that, regarding the overall survival, now if we go back and look at the original publication and we look at the supplementary appendix, I just wanted to bring out this point. This study actually was designed as with primary objective of overall survival. This is the 2016 document, which is there in the supplementary appendix of the original publication. However, when the final publication came, the final publication said primary endpoint was disease-free survival. There is a small, when you look at the full publication, there is a small mention of why they changed and what they changed. I will get back to it. So I'm sorry, my slide is not moving again. Yeah, so Randeep, the relevant endpoint, it's a source of constant debates. This trial, I'm not really going into that debate of whether OS is better or DFS is better. Senthil has also pointed something. I will ask Senthil at the end of this question again. But this trial actually had OS and DFS as co-primary endpoints, and at some point of time, they have changed the endpoint and made only DFS as the endpoint. So it is a trial that changed its endpoint midway. Remember, FLOT was a trial that also changed its endpoint. Randeep, you were mentioning FLOT. FLOT started with DFS as their primary endpoint, and at the request of the data monitoring committee, they changed it to OS. Now, with this sort of change, how comfortable are you when there is no survival mention in the whole publication in NEJM, and DFS is only mentioned, and when the trial actually started with an OS as the endpoint? So what are your thoughts on that?
Bharath, I am comfortable with this. If they have taken the care of the data and the statistical analysis, I am okay. If it would have been that really the number of the patients would have been less, it was a 800 patient trial, as Amish mentioned in the beginning. I'm okay with the amendments, provided the statistical analysis have been taken care of. And you are right, it happens in many of our trials. And touchwood, if you remember Stampede trial, that is the trial which has the maximum changes in the endpoints and divisions. This was just one endpoint, and I'm okay with it.
Okay, just to add to that, when you're looking at the statistical considerations, the protocol, the supplementary appendix protocol document specifically says that 760 patients will be randomized 2:1 for a OS co-primary endpoint. And the final publication says challenges in enrollment and evidence to support disease-free survival as a surrogate was the reason why they changed. And yet they still enrolled 794 patients, whereas 760 patients was the statistical requirement for an alpha of 0.05 and split endpoints for this study. They had the numbers, and in spite of having the numbers, they changed the primary endpoint. Now, I'm not good enough a statistician to understand this point. Dr. Senthil, can you just, sort of take us through this on, why this happened? What, really is the validity of this sort of change in a trial?
Bharath, I think a lot of...
Bharath, sorry.
Yes,
Dr. Senthil, sorry, and Bharath, sorry.
Yes,
I just saw a very nice paragraph by Dr. Sudeep Gupta on this alpha of PFS and OS and why OS has not been reported. So Bharath, before Senthil answers, can I request you if we can invite Dr. Sudeep to explain about this, what you said?
Yes, definitely. That is something that really intrigued me. It would be very useful for all of us.
Dr. Sudeep, Can we request you to get your viewpoint on this? Kashish, is Dr. Sudeep can?
Amish, I'm there. I'm there.
Yes,
Hello,
yes.
sir.
So, hi. I am no expert on esophageal cancer.
But you're our statistics expert, sir.
No, I'm not a statistics expert, and I stand corrected on that paragraph that I wrote there. They have amended the protocol to change DFS to the sole primary endpoint. They are no longer dividing the alpha. But what they mentioned is that OS is now the key secondary endpoint and will be tested in a hierarchical manner. My own take on this issue is that they may have developed a little bit of cold feet about whether they will be able to prove overall survival or not, because when they did this amendment, they had not yet tested disease-free survival. But given the final magnitude of benefit in the disease-free survival, and the fact that they have put in place a hierarchical testing strategy, which means that they will test for subsequent endpoints only if the previous ones are met, I have very little doubt that they will end up proving overall survival also. I think they will do that. And when I read the protocol, for a hazard ratio of 0.71 for overall survival, they need about 440 deaths, which have not yet happened. And I think
yes, it has not happened.
Ramaswamy also pointed out that the follow-up is short as of now. So I think that they will end up proving overall survival. But my guess is that they may have, or the sponsor may have, or the study steering committee may have developed a little bit of cold feet about OS at some point of time during the conduct of the trial. So I stand corrected about the co-primary endpoints.
Very practical answer from Sudeep sir, as always. Dr. Senthil, would you like to add something?
No, I agree with whatever Dr. Sudeep has said. When he said that they would have developed a cold feet, I think it's very probable, because if you look at the DFS curve, you see that it's not separating the first 6 months. So when these guys must have seen that it's not happening the way they like it to be, they would have probably changed this, what I think. But at the end of the day, I think we should take the trial for whatever it is. We should wait for it to mature. And as I was saying, with the kind of events that we have seen, the difference we are seeing in terms of the magnitude, it's highly unlikely that we will not see an overall survival benefit. And there's no reason to doubt the authors that they're trying to conceal something. That's what all of us immediately start thinking about. They've not shown it. So there's something wrong. It's going in the opposite direction. Rumor mills start going haywire. So I don't think there's anything like that happening. So I think that's the most important thing.
Dr. Hollis, so we have resource constrained patients. So we keep talking about low middle income society. So let's leave that apart. So in your patient with an unlimited resource, with all this, we don't have OS data on this. They were supposed to give us that. It's not yet published. Only 24 months of follow-up. The number of events for OS has not reached some 390 odd events. 440 events are needed. So is CheckMate 577 is the answer for all your patients with unlimited resources?
So if a patient with unlimited resources, if I look only at DFS and OS, if I'm looking at OS, I want the patient who is able to take nivolumab in the subsequent line. Now, as Dr. Senthil has also pointed out, very few of my patients will be able to be taking nivolumab in the subsequent line, whether due to fitness, whether due to cost. Here I have patients who are showing a very good DFS. So definitely, if cost is not an issue, I'll be offering nivolumab. The only issue I have is looking at adenocarcinoma in 71% of patients and nivolumab in the subsequent setting, or pembro in the subsequent setting. The data is more for squamous rather than adeno. If adeno is showing such good response, maybe I will push for CheckMate 577 even in most of my patients. Resource constraint setting, maybe no.
Maybe no. Okay. So squamous, yes. Adeno, maybe. And if I understand you rightly,
yes, yes.
Prior therapy, sorry, it's not prior therapy. The radiotherapy doses, Dr. Pooja. If you see nearly 1 quarter of patients receive less than what is cross dose, or the dose has not been reported. Now, how would that have actually impacted the trial? One, adenocarcinoma and squamous cell carcinoma, are you planning, if you're planning, would it be the same doses post-cross?
So, as a radiation point, what we understand that these two entities, adenos and squamous, they really behave different. In terms of the squamous, they always behave better than the adenos. So if you talk about their behavior pattern, of course, we would be tempted to have higher doses to the squamous cell carcinomas, the first thing. Second, having said that, we know that from all the radiation trials, like especially the international 0123, that there has been no benefit of from the radiation part when the dose is more than 50.4 gray in 28 fraction. So in the cross protocol, it is what usually we follow as 41.4. I would not be able to answer this question that how really this, because nearly 1/4 of the patients, they received dose less than 41.4 gray. But I think, I'm sorry, I would not be able to answer this question. How would it affected it?
I would just direct this to Dr. Randeep. Randeep, the patients who came onto the trial with non-PATH CR, 25% have received maybe a suboptimal dose of radiotherapy. Now, in that situation, do you think that suboptimal dose has impacted, or because anyway all of them were non-PATH CR, it would not have made a difference? So, what sort of bias has this prior therapy for 25% actually made, in your opinion?
Bharath, coming to PATH CR, I mean, we are still fighting with having so much data in breast cancer, triple negative. We still get divided in the house that whether PATH CR is a surrogate endpoint for DFS and OS. And similarly, we don't have any such, we have some data, I will not say, but the data is not so strong that I say that yes, pathological CR is the only way to go forward. I think they had to take a subset where really the benefit is there. Tomorrow we will have trials where pathological CR even is not achieved. I believe the benefit will be same, at least for squamous esophagus. Coming to the radiation doses, I may not be able to tell you. And I think in a similar way, when Amish was telling the quality of surgery, the degree of the quality of radiation, how much was IMRT, IJRT, those things definitely help us that how are we compensating. And the typical example in this scenario is whether you have done a D1 or a D2 resection, your adjuvant chemotherapy for stomach cancer changes.
Well, I will come to that. Dr. Senthil, do you think that this pre-randomization 25% difference in the radiotherapy doses would have actually had an impact in the outcome finally?
Bharath, it's always good to have appropriate surgery and radiotherapy. So 25% not having is not a great thing to see in a trial, a controlled trial like this. But having said that, I do not think it would have impacted the ultimate outcome in a big way, because it's only
they would have randomized equally on both sides.
That is correct.
Naturally.
And also that small incremental dose, how much would it have pushed your patient into a pathological complete response is something that we need to ask ourselves.
Okay. Can I make a comment, Bharath?
Yes, definitely.
With regards to radiotherapy, this was a discussion that we had during earlier discussions about the cross trial. See, in the original cross trial, the median length of the lesion is about 4 centimeters, with the range being 6 to 3 centimeters.
8 centimeters. Cross took up to 8 centimeters.
That was the yes, but the median was 4 centimeters.
Median was
4 centimeters.
Yeah.
Now, this is relevant to our population because we see longer and larger tumors. So even that data is not available in this. So we know that it was stage 2 and stage 3, but
we don't know the length
details
of the
about
lesion.
that. We really don't know. Yeah.
Length of the lesion. Dr. Somashekhar, a practical question, before we go. Actually, what % of your patients undergo? I know that, Manipal is one of the, it offers everything that can be offered almost anywhere in the world. It's on par with any center anywhere in the world. But even in such a center, what is the percentage of patients who undergo neoadjuvant chemoradiation for esophageal squamous, gastroesophageal junction squamous, and G junction adeno separately?
Yeah, Bharath, I'll just put it because the whole panel and commentary, everybody is loaded with medical oncologists. Any trial which has no surgical oncologist will see the same fate of a rapido trial. If all the medical oncologists join with radiation and do a trial, and they would look the way different, and when you apply a surgeon, totally different. That's exactly what happened in rapido trial. But when you look at the final thing, everybody's happy with DFS and EFS and OS is gone. Now I'll tell you something about this particular trial. The whole thing in this trial hinges upon following factor. able to complete cross trial, that is chemo RT, number one. Number two, able to do R0 resection, and then residual disease. You know what is this percent of the patient who can complete chemo and radiation? Very good state of patient, good lung, good nutrition, good patients. Number two, able to then undergo a curative esophagectomy, which has 7% mortality without complication of 20%. Able to go to a medical oncologist within 10 weeks of this, and then you do a R0 resection, which itself is 60% esophagus. This is the best rate of a patient anybody can ever manage. Chemo RT completed, able to undergo curative transthoracic abdominal resection, R0 again, and then you are ready to take 12 months of nivolumab. You know, this patient's OS in esophagus, as per all the surgical trial, is between 3 to 5 years. Why are the authors celebrating so early, taking the best group who tolerated all the treatment, tolerated all the surgery, R0 achieved, 12-month nivolumab? It is the best group. Wait for 3 to 5. This is one of the same thing what happened in Rapido, what happened in aromatase inhibitor in the breast cancer, what happened bevacizumab in ovary. It will totally adulterate, clubbing everything. This is not, if this trial is important only between year 3 to year 5. Because how many of you in your practice is going to do it? Number two, you know what? GE junction tumor, not benefiting. So 40% of them are there, which means esophagus. Again, among esophagus, 29% squamous. So if you look at this particular trial, it's very, very important to understand what is R0 in this trial. Now, just now, last week, a large RCT on the surgical trial of esophagus came, multicentric 26 trial. GE junction type 1, type 2 treated by surgeon as a esophageal cancer. You know what is the surgery we do for esophageal philosophy? Total esophagectomy, abdominal lymphadenectomy and two-field and anastomosis in the left neck. Versus treating them like gastric, total gastrectomy, partial gastrectomy. It showed a significant survival benefit if they are treated like esophagus and not stomach up to GE junction 1 and 2. Now in this study, R0 is being commented, not a single word about what is the surgery done. Transthoracic, transhiatal, minimal access open. Did they treat like esophagus or stomach? And what is R0? I'll give you one R0. If you look at the forest plot, the maximum benefit in this trial is N+. There are two ways of achieving N+. Number one, you do what is done, predominantly this is a US trial. In US, the extent of lymphadenectomy is 15-16 nodes. So you pick up few nodes, they are negative, they're all put it as node negative, but bad strata. If you do a right surgery, what is done in Asian countries, Japan, India, Korea, if you do, average 60 nodes are removed. Lymph node ratio is more important. Most of them will be positive.
I have to break in here. I have to break in here, Dr. Somashekhar, because you added India as the right surgery. So, you know, that's very heartening to hear. Please continue.
Yeah, I am very happy because first time ever some adjuvant treatment has come. This trial is in right direction, but not defined the right. You know, it showed a path, but it doesn't show which person should walk through that. So I personally believe when I look at it, thoracic, esophageal, squamous, who really undergo a good quality surgery defined transthoracic and adequate node, and in spite of good treatment has a residual, they will definitely benefit. So this is exactly something very important to understand because there is no surgical arm. That we already have a RCT trial which showed esophageal based surgery philosophy versus stomach based surgery has a surgical OS outcome independent of what medical and radiation does. So we need to define this. We need to tell them to come out with this. I know in US, I worked in US, 99% of esophagus, including mid-thoracic, are treated as Ivor Lewis. Ivor Lewis means upper part of the esophagus, thoracic neck is left behind and nodes are not addressed above the azygos. That, according to all the Asian surgeons, is not an R0 resection. It is accepted by all surgical community and that part is not defined. So I'm very happy if they can define what was R0 in this, because that is the group which benefited. Number two, what was the type of surgery done? Esophageal based or stomach based? Because a lot of GE junction tumors are there, type 1, type 2, type 3. So I would say that this is something which is need to be done. And now that the new evidence of triplet TPF versus 2 is also better, this is not defined that is it only if you give RT it is benefiting because there is no arm. More and more worldwide, the people are moving into triplet and a systematic 3-field lymph node dissection by surgery treating like esophagectomy and then tailor-make adjuvant. Now, in India, I will tell you how this applies. We did a census through a surgical society. Less than 30% of the patient use CROT protocol in India across all the cancer centers. Means RT is not a part of it. It is a neoadjuvant chemo, surgery, and then tailor-made, number one. Number two, how many of them complete cross and a R0 resection with adequate? Not too many of those patients continue. And our Indian patients are predominantly, 60 plus patients, Asian patients. So it's very important to understand we are in the right direction. I will definitely not be surprised if we don't reach a OS, because we are too celebrating. We are taking the best group and we are commenting in first 3 years. Wait for 3 to 5 years. Same thing what happened in bevacizumab and Rapido trial and aromatase inhibitors is going to happen.
So, but thanks, Dr. Somashekhar. Actually, you've answered all the questions that I put up in the next slide also. I always hear this criticism from surgical oncologists about the MAGIC trial, that, MAGIC trial had very bad surgery. And then, you gave chemotherapy and that's why the trial showed benefit. And this trial, of course, we don't know whether it was a bad surgery, whether it was a good surgery. But what we know is at the point of randomization, they were homogeneous. And at the point of randomization, whatever surgery, they have been randomized equally, and that those patients did benefit. The question of whether a different surgery or a sort of better surgery would have made a difference in the trial, would have, sort of negated this DFS, that is something that, really is very difficult, because this trial has not asked that question. This trial has asked the question of what happens in these patients after this surgery. So we don't know that. Maybe it will be a different trial, different evaluation. Dr. Virat, what we do know, we know that there are pre-specified stratification, adeno versus squamous, node positive versus node negative, YP, that is the pathological, and PDL1. So how do these pre-specified? We have all decided, yes, we would give CheckMate 5. We have decided it's a category 1 recommendation. It is a path-breaking paper. We would change our practice based on it. But how would you look at these pre-specified stratification? Would you look at them, or is there no need to look at them, at the end of the trial?
So based on the study, what I would take from this trial is any patient who is squamous, can we go back?
Yes,
for
definitely.
all the three. So any patient who is squamous, any patient who has YP node positive, irrespective of, and preferably CPS, not the TPS, more than 5, I have started offering these patients adjuvant nivolumab. That is my practice since last few months. So definitely I take these pre-specified endpoints very importantly.
You do take this very importantly. But we looked at this graph. Dr. Amish specifically mentioned the more than 1% is crossing the unity, and surprisingly the less than 1% is not crossing the unity. Now in this situation, Dr. Virat has given his opinion. Dr. Hollis, and of course Dr. Virat feels that, the CPS, which was a post hoc analysis, is important. Dr. Hollis, what would you feel, with this showing that PDL1 is actually not really important? You need not even look at this, forest plot or subset. What would you feel?
That's it. The squamous and node positive is what I look for. I will also not look for the PDL1 expression, because the main trial did not have any PDL1 expression. This was a subset analysis. So I will not look much into it, even for CPS, maybe for CPS, but not for TPS. So I might not look much into the PDL1 scoring while offering an adjuvant check.
Okay, Nilesh, Dr. Virat has said that he would prefer the CPS. CPS was a post hoc analysis. The TPS PDL1 on the 28/8 was the pre-specified stratification. Now, if you had to, if somebody says, I have finances, but give it to me if it is useful. In that situation, what would you do? It's a very specific thing. So I have limited finances. I want something to, I will use it if you really say it's going to be useful. Then TPS or CPS, or would you do it at all?
So if you had limited finances, we wouldn't go in this direction at all.
Not limited.
Having said that,
if you say yes, benefit, he may do it.
Okay. Having said that, given the circumstances here, I would do the PDL1 by the TACO 22C3. That's what is being done here. The 28/8 is not available, and I have no idea how to go about it. But I think that at least we know from our lung experience that many of these are interchangeable. That has not been quantified or validated in GE junctions. The other issue is while this study did not specifically look at pre-specified CPS, it did show that all comers benefited from this addition of nivolumab. I am convinced that all comers would benefit from this, but probably the quantum of benefit would be more in those patients who had a CPS of more than 5%.
So we have heard this. So CPS is a post hoc. Now, Randeep, the same question goes to you. So is it no PCR everybody gets? There is no need to look at PDL1 by any platform, or the post hoc analysis? This is the forest plot of the post hoc analysis, not pre-specified. How would you interpret this?
Sorry, can you hear me?
Yes,
Dr.
Randeep.
Bharath, there was a break in the voice. As Viraj mentioned, I will go with those factors more than PDL1. In this particular setting, I will not order a PDL1. If the finance is an issue, I will restrict myself to squamous cell cancer, node positive, not achieving pathological CR, and esophageal. I will totally omit adenos as well as G junctions and node negative, especially finance is an issue. And PDL1 I will not consider in this setting.
I think we have already, Dr. Pooja has already actually looked at this question and said, answered this in the last thing. So I will not repeat it. I will just go a little forward. We have already seen, this is the cross. This is just for sort of what was happening before the trial. We were giving cross for the squamous carcinomas, maybe not for the adenocarcinomas. This is the forest plot of the cross trial. Again, cross had 75% adeno and only 25% squamous cell carcinomas. Very small number of squamous cell carcinomas, but the impact was maximal in the squamous cell carcinomas. You can see that the curves are best separated. The top curve and the bottom curve are for the squamous cell carcinomas. The middle two are for the adenocarcinomas, and which is why sort of cross was more popular for squamous. Now, we are just coming back. This is a repetitive question, Dr. Anand. You had started to answer. So do we have to change now to cross for adenocarcinoma? But unless we do that, we will not be able to stratify into responders and non-responders. And unless we stratify, we will not be able to offer them adjuvant immunotherapy. Is offering adjuvant immunotherapy important enough that we have to stratify patients upfront, even if it's adenocarcinoma? Should we change our practice for adenocarcinoma? It's a category 1 recommendation tomorrow.
Okay. So to me, the easy answer is no, not yet. We do not have the data. I would wait. One of the points Dr. Somashekhar mentioned, a majority of these patients start, unfortunately relapsing at 30 to 40 months. So I would suggest waiting for that data for adenocarcinomas for sure. So I would not change it for that. And I mean, the 3-year survivals in all these trials is hovering around 55 to 60%. This is what I just looked up. So I don't think in adenocarcinomas we would change practice as of now.
So for 75% of patients of this trial, it is not actually, you say it will not change practice, although it's a category 1 recommendation. Dr. Senthil, I will come back to you on that after Dr. Virat has, given his thoughts on this. So if you look at, this is again a pre-specified, the node positive versus node negative. And it's the node positive patients who have actually done well. The YPT status was not a pre-specified stratification. And surprisingly, the T4s, if it was YPT4, they have not done extremely well, or YPT3s. It is a YPT0, that is a good response at the primary, but not so good response at the node that has done well. Why is this a sort of, I see a little bit of confusing. This forest plot is a bit confusing for me. I understand one is pre-specified, one is not. But you should have an excellent response in the primary, but not such a good response in the node. Then that is when you do well with immunotherapy. Why is this? What is the biology behind this?
My take on this forest plot is the first one is a pre-specified, and like you rightly said, if you see the placebo arm, if you have node positive, and if you don't do anything, you just die within 6 to 7 months, or you progress within 6 to 7 months. Versus if you don't, you have 2 to 3 years. So
but that should be true for YPT4 also, right?
So the second one, the second subset is completely spurious. We know from the lessons learned from forest plot, like I was discussing with Senthil sir, You know, there is a study on prostate cancer. A person who is born on Monday, Tuesday, or Wednesday or Thursday does not benefit from docetaxel, while Friday, Saturday does. So this is exactly like that. And I think so this is completely spurious and has no scientific logic for this one. Because if you see YT0 placebo arm progressing in 5 months, while T4 progressing at 14 months, that alone should tell you that the placebo arm without nivolumab so discordant, what you would not expect in your clinical practice.
Great. So, you know,
I would like to add one word here, Bharath.
Yes, please.
I'll tell you, even though we split N plus and T, it's very important to understand that, these T4 lesions surgically, because esophagus doesn't have a cirrhosis, that is the organ, R0s are usually a myth. Every surgeon knows that. The biology of the disease is such that in spite of the best chemo radiation, you persist to be T4. So then the surgeon chance of achieving R0 is not much. It's very important to understand that there is a surgical arm which is also bringing down in T4. Naturally, that is the disease of the esophagus, number one. Second, it is not that, we have N0, N plus and T0, T4. No, there will be again T3, T4 plus N combination. That is not analyzed.
Absolutely.
So if you really look at it in esophagus, rarely it so happens that in node you have, pathological response and primary doesn't. Same like colorectal. So
absolutely, yeah. Dr. Somashekhar,
I don't think we should look into that, because if we have node as responded, take my word, most of T would be towards T0, T1, and they would benefit. And if node has not benefited, they were also T+. So I think the first part is the right one.
The interaction test would show that. Point taken. So let us go quickly because we just have 5 more minutes, and I know Parikh sir doesn't like it if we overshoot. Hollis, this is most intriguing. This is not a pre-specified, but if you delayed starting the immunotherapy adjuvant, they did better. And see the number of patients. 2/3 of patients have started after 10 weeks, and only 1/3 have started at less than 10 weeks. Now, what is your comment on this?
Sir, I'm actually not sure why exactly they are doing this. Look at the nivolumab adjuvant also. As the earliest, they are doing better. But
yes, but here this seems to be different. Yeah, it's a paradox. Dr. Senthil,
I can answer it very easily, Bharath. Surgeon only can answer this. I'll give a classical example. For every
week, quick answer, sir.
Yeah, every week a patient of ovarian and esophageal after surgery reports late for the prescribed adjuvant, they start losing roughly about 1 to 2 weeks. So why would a patient go late after 10 weeks? They had a surgical complication. They took more time to recover. Minor surgical complication with nutritional problem. So surgical effort were more because the disease was more, burden was high. So, that itself is a wrong. It's a sort of bias that in a proper surgery, invariably within 4-6 weeks, patient would go. If somebody doesn't go, means there is already a delay. So if you have a best proof of molecule, like you want to use a checkpoint inhibitor, the group in the placebo arm, which is the worst group, who had a complication, who are not going on time.
Yes, point taken.
You have a very good wonder drug on the other end. So next
yes,
they will show it's a poor arm on the other end.
Dr. Somashekhar, let's move. But point taken. You say that they did better because the surgery was better, which is what delayed the start of therapy, and it is not the effect of nivolumab. They're doing better because it's the effect of better surgery. Now that's a very, very controversial point. I wish we had more time to discuss this, but I'm sure everybody has heard. We will come to the comments on it. Dr. Anant has referred to the sort of DFS from cross, flot, and neocritic. I have not put the overall survival because this trial did not have overall survival. We have a median PFS of 37 months in the cross, much higher in the squamous, a little lesser in the adeno. Flot had, of course, only adeno, it was 30 months. And neocritic, which is a much older study, 2006 study, but again, a Chinese study, Asian study, which had a very, very large DFS of 100 months. Now, this study has only a DFS of 11 months, which is, sort of consistent between both the adenos and squamous in the standard arm, not in the placebo arm, not in the nivolumab arm. So the question to you, Dr. Nilesh, is the sort of DFS slightly lower in the placebo arm than what you would have expected in practice for cross or for any other type of therapies? Is the placebo arm doing worse than historical controls?
So at first glance, that's what it looks like. But if you really give it a thought, you do realize that this is a highly selected population. So this is not the original cross group of patients that you are looking at. You're looking at a group of patients who did not achieve path CR. That is, they are one of the worst prognostic group of the cross, and therefore I think it's acceptable that this 11 months DFS that I see in the control arm is not very surprising.
Not
And
surprising.
it's acceptable to me.
It's acceptable. Dr. Randeep, so is there any alternative strategy in the sense that now neo-aegis has also has come, as Dr. Anant, you could use a neoadjuvant immunotherapy also. So is there any other strategy that you would consider based on any phase 2 trial for immunotherapy rather than this 1 year adjuvant?
So as of today, I mean, as of Monday morning, no, but yes, we are all aware that yes, they will enter neoadjuvant, and we have trials going on for this after, I mean, you do the flot and then you give chemotherapy. That will be soon out in another 1 year or so. That result will be published. So, I don't remember the name of the trial. The results will be published soon. And then if that result is positive, this confusion of treating GE with adjuvant immuno will also finish.
So I think
the based trial, I think.
The point is that, things are going to change very soon, both in the neoadjuvant setting and for adeno in the adjuvant setting. Dr. Vijay, is there anybody with no PCR who would say no nivolumab? Just quick answer. Now we just want quick answers.
So squamous, again, I'll repeat my same answer. Squamous, node positive, and CPS more than 5, yes.
Okay.
Rest of all them, no.
No. Hollis, so do you think that flot EOX has any future, or should it be just, we should change to anybody? Or what do we do with CIVOT 2-3s? What do we do with flot and EOX? Do we just change now? Yes or no?
I will still with 3 CIVOT 3 to definitely flot CIVOT 2, definitely a tumor go. But yeah, I'll not be comfortable with CCRP, neoadjuvant CCRP in CIVOT 3. So yeah, adeno, CIVOT 3, flot.
Anant, I have already started seeing extrapolations of CheckMate 577 in practice. I have not done it, but I have seen nivolumab being used after flot when there is no PCR. I have seen nivolumab being used in R1 and R2 resection patients after chemoradiations and esophagectomies. And it may even, some people may even say, if it works, in non-PCR, it may work in PCR patients also. So what's your opinion about all these extrapolations? And remember, there will never be a trial for R1 and R2 patients. That's never going to be there.
Yeah. So I think
they may be the best ones who benefit from immunotherapy.
Yeah. So R1 and R2, you're never going to get an answer. You're always only going to do examples, So I have no answer to that. All other extrapolations I would avoid for sure. Because, post-flot, absolutely not. We're not even sure if the adeno-CAs are going to benefit as much with adjuvant nivolumab. So why, tamper with that? R1, R2, anyone's guess. They are going to do badly irrespective. I don't think the immunotherapy will actually work more in them because, they're at a high risk of relapse per se. So, I would not go with these extrapolations.
Dr. Nilesh, is there level 1 evidence, with just an OS, with known OS benefit and follow-up of just 24 months for this trial? What would you, say this is level 1 evidence, not category 1 recommendation? I'm asking you whether it's level 1 evidence.
So the level 1 evidence would depend whether you are satisfied with using DFS as a surrogate for OS. If you are, then yes, this is level 1. Having said that, like we mentioned earlier, I would prefer to use this for squamous cell carcinomas and a higher CPS, not for all comers.
So, but you would say this is not level 1 evidence?
I'm convinced it is level 1 evidence. Because
you are convinced it is level 1 evidence. Okay. Okay. So Dr. Somashekhar has also answered this. So I'm just going fast. Now, post-progression therapy, very, very few patients actually took up any sort of significant post-progression therapies, around 30% in the nivolumab arm and around 40%. Now, Dr. Virat, is this the way? Is 40% your usual post-progression therapy for esophagus?
No,
is this consistent?
No.
Only 40% of patients in the placebo arm took any form of post-progression therapy. 60% did not take.
Correct. So
this is even worse than flot.
This is even worse than my practice. So this is worse. Secondly, out of them, how many took immunotherapy? Because that is approved.
7%.
7%.
We are comparing nivolumab versus no nivolumab rather than nivolumab first, rather than nivolumab later. So I think so. My main criticism about this is you're not comparing apples and apples. You're comparing nivolumab versus no nivolumab, and that is not how adjuvant trials should happen.
Dr. Senthil, this 40%, are you okay with this 40%?
So I think that number could have been a little better, but my rebuttal to what Viraj is saying is that you should consider two important things. One is what was the standard of care when this trial was designed and these patients would have relapsed. First line immune checkpoint inhibitor was not standard of care. Immune checkpoint inhibitor in the second line offering 2-month overall survival benefit was what the standard of care was when patients in this trial would have relapsed. Okay, so you don't expect them to be managed like your CheckMate 648 or 649, whatever that number is, wherein you're giving them nivolumab upfront. Remember also that not all patients when they relapse will get whatever is the so-called standard of care. You cannot design a trial wherein all patients in the standard arm were then crossed over at a later point in time, and this is very classical for everything starting from Adjuvant to CTONG to every trial that you're talking about.
But not in the earlier lung trials like gefitinib or.
But most of the trials that happen now, it's not, Viraj, it's not that they're keeping patients away from therapy. That's the way things happen. Remember that if this is what happens in a clinical trial, it's worse in real life.
So if I can, just break in because we are really out of time. Sure. I will request Dr. Amish for 1 minute and, just ask these 4 questions, just yes or no answers from all the panelists. So with all this, some won't give it for adeno, some won't give it for CPS less than 5. Some will not consider cross at all as a, upfront therapy. And of course, Dr. Somashekhar has given many valid points. So with these, what we have discussed, just poll questions, 30 seconds. Is CheckMate practice changing for your patients with esophageal cancer, adeno and squamous? What is there for this in this trial? Exactly this trial. The PFS has doubled. Is it practice changing for you? Yes or no from everybody?
Yes.
Doctor, that was Virat, I think. Dr. Senthil?
Yes.
Dr. Somashekhar? Dr. Pooja?
Yes.
The medical oncologist, Dr. Randeep?
Yes.
Hollis?
Maybe no.
Hollis?
No, sir. Only for pharmaceutical.
No, not practice changing. Anand? Anand?
Not yet.
Not yet. So 3 people have said no. 3 people have said no, it's not practice changing. So do you accept the NCCN category recommendation is based on a level 1 evidence? Again, let us start with Virat. Virat, yes or no? Virat? I can't hear him. Dr. Senthil?
Yes for squamous, CPS more than 5 and node positive.
Okay, so it's no actually because it's category 1 everywhere. So your answer is no. Senthil?
Yes, since if the answer to the question number 1 is yes, the answer to question number 2 has to be yes.
2 is yes. Dr. Somashekhar?
Absolutely no.
Absolutely no. Dr. Pooja?
Yes.
Yes. The medical oncologist. Of course, Viraj is also a medical oncologist. Dr. Hollis?
No, sir. No, sir.
No. Dr. Randeep?
I have to say yes, as per the logic, Senthil is absolutely right.
No, you can change. Senthil's logic is his logic. Senthil is a brain that is far beyond our brains.
If you allow to put that condition, then I will agree with Viraj. It is conditional. It is more for
conditional. Then it's no. Conditional is no. Conditional is no. And who have I left behind? Anand?
No.
Have I left behind anybody?
Me. Yes.
Yeah. Who's that?
Nilesh.
Nilesh. Sorry, Nilesh. My best friend, Nilesh. Yes. What was your answer to the previous question?
Yes.
Nilesh?
It was yes.
It was yes. So yes, but we have 3 no's and 1 conditional, which I take as no. So I think everybody has answered no. I'm going to rush through this. Most of you have already said no to this. So I'm taking
Bharath,
this
here
no.
I will also say no for that question.
Yes.
Because
so
my
no.
way of managing adenocarcinoma is not chemoradiotherapy.
Okay,
so that's
so
something
then,
that I want to qualify.
So then fine. So the unmet need for neoadjuvant, in patients post neoadjuvant is only partially addressed with this trial. Immunotherapy strategies may improve PCR if it's given in the neoadjuvant setting, and the CheckMate 577 status is going to be challenged very soon. I think in next 1 year, we are going to have a totally different discussion. So this may become redundant, irrelevant very soon. Patients with PCR also relapse, which has not been addressed. and clinical practice has a large number of patients with R1 and R2, which Dr. Somashekhar, emphasized, very emphatically said, which is not addressed in this trial. And results of the standard of care arm seem to be slightly poor, which I want the last comment from Senthil on that aspect. And adapting a patient, adapting a strategy of CheckMate 577 means considering neoadjuvant CCRT, which is, fitness may not be present for many of the patients. Doubling of DFS is very promising, and it may most likely result in OS. However, that needs to be seen. I too, like Dr. Sudeep said, I too expect that the OS is going to be there. So with that, is the, sort of standard of care arm results slightly poorer? Dr. Senthil, your last comments, and I will, hand over the mic.
Before Senthil says, with your conclusion, I can make out you are with all of us nose. That's why your conclusion is all.
No. I am not with nose. I am not with nose. I have just, taken out the trial. I've taken out the supplementary appendix. I've put the, data for you. I am not with the nose.
So the standard of care arm is performing a little lesser than what we would have expected it to do, Bharath, and that's why the question of adequacy of surgery and all that came up. So that's important to understand, but I don't think that would change the way we look at it. For adenocarcinomas, I think all of us are on the same page that we should be doing, perioperative chemotherapy. For patients with squamous, it should be chemoradiotherapy. And then, I wouldn't want to qualify saying CPS, node positive, node negative, YP T1, T2. I think if you've got chemoradiotherapy and if you've got a residue, we should certainly consider for 1 year of nivolumab. So that's.
Thank you. Apologies to Dr. Amish and Dr. Parikh for running over time.
Bharath. Sorry, just a little rebuttal on what Senthil has said. I can try to do that. See, the placebo arm, as Bharath, you rightly mentioned, is 11 months in both adeno and squamous. And this is the group of patients where you have 50% YPN1, more than 50% YPN1. So if I understand correctly, this is a very high risk group, irrespective of adeno or squamous. I think that is how I would look at this trial, rather than just thinking that the placebo arm has done not well compared to what the historical standard. That is what I would say.
Amish. You're right. So, this is a poor prognosis set patient. So you expect the numbers to be lower than what you would get in a trial where all comers are there.
Correct. Perfect. Bharath, excellent. Over to Parikh, sir.
Thank you very much, Bharath, and thank you very much for all the panelists. It has been a very lively and interesting discussion with a lot of viewpoints. And I was just trying to remind everybody that while data may come out in the future, we were wanting to discuss what we would do for our patients today who cannot wait for tomorrow. Before I introduce another great friend of mine, Dr. Ghanashyam Biswas, I would like to also share with you that the next Oncology Beyond the Obvious will be on the second Tuesday of October, that is 12th of October. And I was thinking of telling you that this is shifted from every 2 weeks to once a month, so that everybody has an opportunity to have a fixed date, second Tuesday of every month. But it's also because this Oncology Beyond the Obvious is too much work. I think Amish and I have to do a lot of work and a lot of discussion and interaction with the faculty, especially the invitees and interviewee and the moderators, so that we deliver the best possible outcome to the audience. And I think we are exhausted, so we can't do it every 2 weeks. We have to do it once a month. Now let's hear the expert conclusions and the way forward from Dr. Ghanashyam Biswas. He is a leader by himself in many ways, and he is, I think, the senior most medical oncologist in the whole of Odisha. And he is an example for anybody who wants to develop his own hospital and practice. There are other features that you all already know, so I will not waste further time. Over to you, Dr. Ghanashyam Biswas, for the expert conclusions and the way forward.
Yeah, thank you, sir. Good evening, all. And I think so Oncology Beyond the Obvious. So it's a blockbuster program in this pandemic, and I welcome this. And so that's the brainchild of Amish, and definitely supported by Purvish. So definitely you heard the interview. So we heard all the views of the moderator, Bharath, and all the panelists. So the first question was, do you agree with Dr. Senthil? So Dr. Senthil, as Amish mentioned, so is the common oncologist voice of the medical oncology group. So yeah, so we are talking about a disease, esophagus, which is probably in 2021 is much worse than a lung cancer. So lung cancer during our DM days. So and today the lung cancer, even in a stage 4, we know that there are survivors for years together. So the scenario, so there is definitely a medical need. Second, we talked about hazard ratio and p-value. So p-value 0.000, so is a dream for every medical oncologist, but hazard ratio actually give the quantifications. So coming to DFS and OS, and we have seen in the recent past also, so many a times, so are you into the getting trapped into the medical or the pharmaceutical companies? And we know that 3 years back, the story of a beautiful drug in a sarcoma setting, olaratumab, which was doing so good in regards to DFS, but the phase 3 OS and more structured trial absolutely showed no benefit. So we are thinking of a drug after 4 decades in a sarcoma, but it ultimately turned out to be futile. So unless and until OS data is there, so we are not very sure. So will you change your practice on a Monday morning? So for a definitely a fraction of patients, a squamous cell carcinoma, a high CPS score, and definitely a residual disease, because we know that for a residual disease, these patients are definitely not doing good. Most of these will land up for a palliative chemotherapy or immunotherapy, and we know that so 1/3 probably will come as a second line treatment. So when will you consider? So probably at least more than 10 weeks, we have seen that they were benefiting with a hazard ratio of 0.66, where, so we know that squamous cell carcinoma, high CPS score, and definitely with a residual disease. And why? So as of now, at least of 24 months follow-up, we have a doubling of PFS. So that's important. So the strength was that, so we are looking at a medical need in a disease which has a 5-year survival of less than 15%. And the beauty was that 2:1 randomization. So at least, so 2 out of 3 patients were receiving some newer therapies. And there was definitely a better local control and systemic control, because all these patients had received radiotherapy, probably there was some abscopal effect. So definitely there were some lacunae or weakness. So mixing of the 2 heterogeneous group, we know the squamous does better than the adenocarcinomas. So all adenocarcinomas with the G junction have received chemoradiotherapy. So we know that type 2 and type 3 will receive, in fact, FLOT. And third, so whether it is a DFS or OS, so this is going to continue, but not validated in many of the gastroesophageal cancers as the primary endpoint. As per Dr. Somashekhar, definitely this trial has picked up a best group. So in regards to that, so probably it's time that for a few more years of the OS data, or at least the first OS curve is there. So we don't know. Now coming to, so many countries were involved. And so this is one of the common 10 cancers in the world and also in India. But Asian patients were less than 15%, and India was not a part of this trial. So though many parts of these countries sees lots of esophageal cancer. Second, if suppose in the Monday morning you start this patient on a nivolumab adjuvant, so 2 weekly 240 milligram dose, you require 8 doses, 480 milligram every monthly 8 doses, so 16 doses. If the PAP is there, if the DCJ approved, so then 16 lakhs rupees. And we know BMS as a company, so if the PAP is not there, so you require first 4 months of 20 lakhs, and then after 8 months, that 480 milligram will be on 40 lakhs. So with PAP, 16 lakhs, and without PAP, it's just 60 lakhs rupees for a 1 year at this moment of 11 months of DFS benefits. So that's my take of today's CheckMate 577. So over to you, Parikh sir and Amish.
Thank you very much, Dada. Excellent conclusion, and obviously we are always going to look at further data as it comes in the future to modify the way we treat our patients. And what we can do today is based on whatever data we have. And in the panel, we have clearly seen that there is a distinction or difference in how people perceive it. And that is why we wanted to discuss the entire session in today's Oncology Beyond the Obvious, because it makes it clearer for the audience and for the community oncologists as to what are the negative and positive aspects. And based on that, they will then decide what to do in the individual patient in front of them. The next Oncology Beyond the Obvious is on 12th October. And from then on, it will be on the second Tuesday of every month. The topic of the next one is Keynote 522, which is neoadjuvant pembrolizumab combination for early triple negative breast cancer indication. So with that, I thank everybody. Stay safe. Good night, and see you in a month's time on 12th of October.